Welcome students to lecture 22 of BMS256, looking at exercise prescription for populations of hypertension and cardiovascular disease. The focus in this lecture is mainly directed towards hypertension. It's going to be one of your specific populations in part 3 of the exam, where cardiovascular disease is not. However, the impact of cardiovascular disease still has that important role, and the mechanisms that cause these diseases may interact with other diseases that we've previously discussed. Because this is a recorded lecture, there's some extra reading that give a good overview of hypertension and exercise. However, to do well in the exam, all the info will come from this lecture. So same objectives as all our specific populations, briefly describing the pathophysiology of hypertension, how does exercise improve the health of people with hypertension, what type of exercise prescription will benefit hypertension and the reasons behind that, and then what are the risks of exercise for people with hypertension. The cardiovascular disease objectives are a little bit broader and specifically looking at the benefits and risks with exercise. So starting off with hypertension. So our textbook healthy or normal ranges for blood pressure are a systolic blood pressure of 120 mils of mercury over 80 mils of mercury for our diastolic blood pressure. So hypertension or high blood pressure is a systolic blood pressure of 140 and a diastolic of 90 or higher. Now remembering that systolic pressure is measured in that emptying phase of the heart, so when the left ventricle squeezes, shunts the blood out of the heart into the vessels, and diastolic is that refilling period. Hypertension is one of the lifestyle diseases that we've sort of been looking at. So it's linked to your diet, obviously a diet high in processed foods due to the salt content, alcohol consumption, obesity, diet low in potassium, and like we'd hope with this subject, exercise has a large impact on your blood pressure and leading to this disease. So we'll look at further on at how acute bouts of exercise or even a single bout of exercise can reduce your blood pressure, and then the chronic adaptations that can be made as well. There are some genetic factors that can lead to hypertension. And there's also a correlation between the percentage of type 2 muscle fibers and the incidence of hypertension. So that has a large impact on people of different races. And we'll look at a graph in the next slide looking at African American males and their incidence of hypertension. So if hypertension is not detected or treated, can lead to pathological cardiac hypertrophy. So that increases your risk of heart failure. So obviously that left ventricle has to work a lot harder to shunt blood out of the heart, putting your body or your heart at a large risk. Also see formation of cerebral aneurysms, which can cause stroke, renal or afferent artery stenosis. So that's going to lead to kidney failure and a loss of compliance throughout the entire cardiovascular system. So like we've talked about, all subject with age, we get that stiffening of the cardiovascular system. So we get a less stretchy system, less stretchy vessels, less vasodilation, not enough of that nitric oxide that we need to relax those vessels and allow for better exchange. So this is going to expose us to an increase in hypertension and making us more prone to other cardiovascular diseases. So looking at hypertension and aging, so there's several studies suggest that regular exercise can actually prevent the development of hypertension. So this graph shows the incidence of hypertension with age. Like I spoke about before, as we get older, we have less compliance of that cardiovascular system, everything from the heart to the vessels, decreases in ability to allow blood to flow under less pressure. We also see a large difference in races. So this was an American study which split groups into black and white populations. And for both male and female, the African American population had a high incidence of hypertension throughout all the ages compared to white males and females. The reason for that being the African American population has an increase in type 2 fibers, increasing their risk of hypertension. Lifestyle modifications that can be made to reduce the incidence of hypertension. In addition to medication and exercise, we can change our diet to monitor our weight control, reducing sodium chloride intake or salt intake. So that's eating less processed foods, less salty foods. And the reason for that is because salt has a high osmolality, so we need a lot of water to bind to that salt. Also, a big factor now, and literature is starting to look closely, is the amount of sugar, because sugar has a high osmolality also, which requires a large amount of water to bind to it. Alcohol's a big factor. It imbalances the central nervous system. It increases sympathetic activity, which then stiffens the vascular system. We also need to consider that even though these lifestyle modifications are made, it doesn't affect everyone. Some people that have genetic factors or history of hypertension, even if they make these modifications, may not make any difference. So the health benefits of exercise on hypertension. So we get two types of adaptations, chronic adaptations and acute adaptations. So acute ones that are happening quite rapidly. And with a single bout of exercise, obviously as we begin to do our workout, whether it's walking, strength activity, whatever it might be, we get an increase in heart rate due to the need for increasing cardiac output. So we get an increase also in that systolic blood pressure. Okay, so that emptying of the heart creates extra pressure on those vessels, increasing the systolic blood pressure, but we get a little or not much of a change in the diastolic blood pressure. Immediately following exercise, systolic blood pressure will actually fall below pre-exercise values for the next 22 hours. And for the next 2 hours, we see a decrease in almost all values. So whether it's systolic pressure, diastolic pressure, or the mean arterial pressure. So a single bout of exercise, obviously an acute response, has that hypertensive effect. Now, this effect is unclear. So that's going to be probably a common message throughout this population because the reasons behind it aren't fully understood yet. One possible reason that this would happen is due to vasodilation. So obviously having a wider blood vessel, a more stretchy blood vessel, relaxed smooth muscle in those vessels is going to lead to less resistance. Okay, less peripheral resistance, less pressure going to those vessels, going to make it a lot stretchy and make for that exchange a lot easier. So this is going to have a decreasing effect on our blood pressure. Also a decrease in sympathetic activity, so less stiffening of the blood vessels, a lot more blood vessels that are opened up in the muscles. Like we know with exercise, our blood vessels open up at those working muscles to lower that resistance that the blood has throughout the arteries. Also, a good response of hormone receptor activity. So, acute exercise can actually block the angiotensin 2 receptor, which signals the hormone aldosterone. And aldosterone is the main hormone that affects hypertension. So, if we can block the receptor, it helps regulate the amount of vasoconstriction and helps maintain pressure within the arteries. So here's one study looking at the health benefits of acute exercise. Those first three graphs there are all blood pressure values. So before exercise, they're significantly higher. And after a bout of exercise, so in this study it was a 45-minute walk at 70% of their heart rate, or 70% of their max heart rate. So for all values post-exercise, values were decreased. The first one being systolic pressure remained lower for up to 2 hours, and there's been studies to show that even after 22 hours, systolic blood pressure stays lower. Mean arterial pressure, which is a calculation based off 1/3 of your pulse pressure plus your diastolic pressure, remains significantly lower, and even diastolic blood pressure, so immediately after exercise, remain lower, and then a gradual return after an hour. So this study looked at the chronic response of exercise and hypertension. So the first study was conducted over 16 weeks, and the second study conducted over 32 weeks. Both significant changes or decreases in blood pressure, and benefits were noted even after 3 weeks of aerobic exercise. So the numbers, so the mean values, showed a significant decrease, especially in systolic blood pressure. So it went from 138 mils of mercury down to 131, which is a lot better than most hypertensive medications. And it's great to see these positive responses from exercise, because medications have a pretty bad effect. They actually make you feel dizzy, can lead to high blood sugar. There's a lot of factors that aren't really great for continual use of hypertensive medications. In the 32-week study, blood pressure values continued to drop, and it was noted that if training continued for more than 3 months, improvements would still continue to be made. So exercise prescription with hypertension. So it follows that same theme from ACSM, which is 150 minutes per week of moderate activity. Now, like we saw before with the acute responses, it's great to have frequency. If after a single bout of exercise we can reduce our blood pressure, if we do frequent activity, we can maintain that lower blood pressure throughout the day. There's no optimal intensity noted, but some studies show that the older population benefit off a low intense activity, and younger people benefit from a high intense activity. Obviously, this could do with motivational factors, younger people wanting to push their bodies a little bit further, and older populations probably not so, just wanting to do slow rhythmic activity. In your exam response. You can note this, that there's an unclear or optimal intensity. So as long as you justify that, that's going to be a great way to write into your program. So you might say you started off doing a lower intense program, and then as their confidence improved, you started getting them doing higher intense activity. So that could be one way that you progress them. Obviously, frequency needs to remain high, and the reasons or mechanisms for that were clear because it lowers or has that acute response to exercise. Now, strength training and hypertension. So we talked a bit last or the first half of the year about how strength training can affect blood pressure or increasing blood pressure due to the straining in the muscles and the constriction of the vessels under heavy load. However, the chronic adaptation outweighs the short-term response. So if you're careful about the prescription of exercise, then it'll have significantly better or beneficial effects. So it's recommended for to use major muscle groups, and again that focuses on the use of making it functional. So if you're training to help them walk, using lots of lower body muscles. If you're training to make them swim, upper body muscles, being able to lift themselves. If it's an elderly population, lift themselves out of a chair. If it's a younger population, helping them compete in their sport or just remain physically active. Avoiding maximal lifts, so obviously not putting too much strain. So emphasizing on lifts with repetitions of 12 to 15, which is a little bit higher than what we've seen in most ACSM recommendations. This is because low weight, high repetitions, still getting a lot of strength benefits, but just not that bodybuilding type of increase that we want to see. So it should be done in conjunction with aerobic training. So this offsets the left ventricle hypertrophy and loss of arterial compliance. So we don't want to be placing too much stress on that left ventricle, which is the one that's pumping into those vessels. So if they're already tight, this is going to place more stress. So here's an example of strength training, and this is especially important because obviously not everyone is going to enjoy aerobic activity. So if we can write a strength program or resistance training program, they can still enjoy this without the risks. So again, those high amount of reps, probably starting off with a single set. And again, this is where you can apply the overload principle. Using 8 to 10 different exercises. Obviously, if we're progressing, you might start off a lot lower, so 4 to 6, and then progressing 8 to 10 exercises within that set of resistance activity. So a lot of examples there: shoulder press, extensions, curls, even abdominal activity. And again, performing 2 to 3 days a week, so a high frequency, and using that Borg scale or rate of perceived exertion. So the full Borg scale is 12 or 13, which is somewhat hard or just over that moderate. If we're using the reduced Borg scale, looking at around 6 to 7. So if we were to make a mesocycle, we could increase the number of sets. Okay, we could increase the amount or the type of exercises, so going from 4 to 6 to 8, which is recommended, or increasing the frequency as well. So there's lots of ways that you can progress this population in terms of resistance activity. So the benefits of exercise training for people with hypertension, again, the mechanisms are unclear, but improving that vasodilation of blood vessels is one of the major factors. So increasing nitric oxide synthase is something that we've talked a lot about, which improves with exercise. and that leads to chronic increase in nitric oxide production. That makes those vessels nice and stretchy, improves exchange, which would lower the resistance at those peripheral vessels. Also suppressing the sympathetic activity and that hormone receptor response to angiotensin too. So you don't get that hypertensive effect from that release of aldosterone. Other physiological adaptations will improve, so cardiovascular compliance, the reduction in the stiffening of those arteries, the contractility of the heart also improves, and also, like we've talked about many times, the benefits to do with social and psychological health. Some of the risks of exercise with hypertension. So the conditions that you train in can obviously affect, so making sure it's not extreme heat. Also being able to monitor the blood pressure if possible over those initial weeks of training. Taking into consideration what type of medication they're on. So if they're on beta blockers, that's going to affect their heart rate. So not using a heart rate monitor or going off percentage of max heart rate for intensity, but rather using that RPE scale or the Borg scale to measure or monitor intensity. Using a slow warm-up to reduce the chance of a large increase in blood pressure, and a slow warm down reduces the chance of dizziness. Also, with the blood pressure medication, they have a slight diuretic effect, so drinking lots of water and making sure that body temperature is well regulated. Now looking at exercise and cardiovascular disease. So cardiovascular disease is the leading killer among people in developed countries worldwide. It's responsible for 30% of all deaths. And atherosclerosis is the underlying factor of 85% of cardiovascular diseases. So atherosclerosis is the hardening of those arteries and building up of plaques, putting risk to blood flow. Cigarette smoking is the most important of the known modifiable risk factors. So exercise with cardiovascular disease. So people with cardiovascular disease show stabilization or regression of atherosclerosis with a combination of exercise training, diet, and drug therapy. Before intervention with exercise or starting an exercise program, it's important that a full pre-screening is undertaken, so medical history, physical examination, obviously by a physician first, to make sure that physical activity is going to be safe, and then laboratory assessments. So things like blood tests could be taken to look at triglycerides or cholesterol in the blood, and then physiological testing, which is usually performed by a cardiologist using a graded stress test. So a graded stress test is symptom limited, performed in a laboratory. It evaluates the cardiac function under conditions that exceed resting requirements. So it's very similar to the VO2 max test that we did, starting off at a low intensity, gradually increment the intensity, so either by speed, power, or workload, and it can be performed like we saw in the lab on a bike or on a treadmill. Does not require maximal effort, but people reach at least 85% of their predicted max heart rate, and this is because if someone's got an underlying or unstable heart, then it's far too risky to be taking them to their maximal level. So the reasons why someone would want to do a stress test is it can help diagnose silent or abnormalities So it's usually performed with an ECG connected to them, so that's recording the electrical activity of the heart. It screens so you can perform exercise training and will be able to find out what intensities or what levels you're able to push yourself safely. It helps uncover abnormal blood pressure responses, and it monitors the effectiveness of training. Why you wouldn't perform this test is presence of acute or unstable cardiac diseases. Obviously, you don't want someone having an incident while they're performing the test, and it's just far too risky to push them to their maximal level. So looking at two major diseases now with cardiovascular disease, the first one being coronary artery disease. So coronary artery disease is the progressive narrowing of the coronary arteries, or the arteries that go or are in the heart, due to atherosclerotic plaques. So atherosclerosis is all the vessels around the body, and the coronary artery disease is just looking at the vessels somewhere in the heart. It's likely to lead to angina, so chest pains due to that low blood flow in the heart, or even leading to myocardial infarction. So risks include cigarette smoking, hypertension or high blood pressure like we looked at before, physical inactivity, so not being able to get that blood flow going around the body and all the benefits that go along with physical activity, so you don't have stretchiness or the compliance of those vessels, and also stress can lead to is one of the leading risks. And like this subject leads to, all of the risks are reduced with regular endurance training, and again those mechanisms include the ability to make those vessels stretchy, increase or lower that hypertension, and making your risk factors a lot lower. So exercise and coronary artery disease. So even if someone is suffering from coronary artery disease, if they take on an exercise program, they're still able to get the same improvements. So structural and functional changes in the myocardium, obviously making the heart stronger, able to get that blood through easier, or to reduce cost, reduce heart rate and blood pressure. So with all those physiological adaptations to exercise, we see that reduced heart rate, we see a reduction in blood pressure, which means the heart has to work less. So even if you have a sick heart, it's able to perform less work, which makes it a lot easier. Again, using the RPE scale is going to be important to prescribe intensity, rather than looking at the actual max heart rate percentage. Knowledge of cardiac medication, again if they're on beta blockers, that's going to affect the response to exercise and also the intensity that you prescribe. It should be personalized, and often combining aerobic and high repetition resistance exercises. Like we talked about with hypertension, the low repetition exercises may give a short-term increase in hypertension, so that's placing them at a higher risk. So keeping the reps low, allowing for slow, gradual benefits to be made from strength or resistance activity. Peripheral vascular disease. So it's due to atherosclerosis in peripheral vessels, mainly down in the feet, and the risk factors are the same as coronary artery disease. The most frequent symptom of peripheral vascular disease is intermittent claudication, which is pain or cramping in those peripheral muscles, so down in the feet, down in the fingers, leading to a lot of people with this disease not actually wanting to undertake any activity at all. If you could imagine having cramping or pain in your legs before you undertake activity, it's not going to really make you motivated to want to walk So it's going to be a lot of symptom-limited factors with this disease. So treatment of peripheral vascular disease is to improve walking ability and functional status by reducing claudication symptoms and preserving limb viability. Reduction in the risk of cardiovascular events by treatment, and trying to figure out what's causing the atherosclerosis. So whether it be dietary factors, genetic factors, or just a reduction in physical activity. So looking at the benefits of exercise with peripheral vascular disease, like we said before, one of the limiting factors is if you've got cramps and pain in your legs before exercise, you're probably not going to want to go out and walk or jump on an exercise bike. However, there's massive improvements with exercise compared to drug intervention. Like you can see by the chart on the bottom, there's up to 150% increase with supervised activity in peripheral blood flow. The peak oxygen consumption in patients with peripheral vascular disease is usually 50% lower than that of age-matched individuals. Obviously, if your body can't deliver oxygen to working muscles, you're going to have a decrease in that cardiac or that cardiac output going to those muscles. This leads obviously to deconditioning. So if you can't get that oxygen down to those muscles, you're going to have a decrease in muscle mass, a decrease in muscle strength and endurance, which sort of feeds almost a positive feedback loop. So if you haven't got that muscle mass, you haven't got the strength, it hurts to exercise, you're going to want to stop, or your motivation is going to get lower. So having all these symptoms makes you want to stop, and then the symptoms get worse. So trying to have an exercise intervention is going to significantly improve this population. So looking at some examples of exercising with peripheral vascular disease, like we've talked about before, exercising or the onset of exercise opens up those blood vessels going to working muscles. So being able to exercise with this disease is going to significantly improve the blood flow going to those peripheral vessels. Warming up and cool down is going to be important just to get those vessels open, getting blood down there to the muscles that need it. Walking is the recommended activity. The reason for this being that it can be supervised quite easily. So it could be on a treadmill, it could be on a running track, it could be up and down a hall. It could be with a health professional, or if they're doing it on their own, it could be with a frame so that they can stop and take rest if they need to. The type of exercise is also important, so that work-rest interval style session. So working for a period of time, stopping, resting, just to gradually reduce the symptoms or make those symptoms not as harsh. So if there is claudication or that pain or cramping, rest until symptoms cease and then begin exercise again. So continual exercise, rest intervals for 35 to 50 minutes, 3 to 5 times a week. Like we see, a single bout of exercise is going to make a significant improvement. So if we can keep that frequency high, that's going to improve their health benefits for a longer period of time. Obviously, cold weather promotes vasoconstriction, so it shuts down those peripheral vessels. So trying to avoid exercising in cold conditions, making sure hands and feet are nice and warm to allow improved blood flow and circulation is going to be important. So to summary, the acute response of exercise is significant for hypertension patients. So blood pressure falls for 22 hours post-exercise, and like we saw in that study, significant improvements 2 hours post. So that's why it's going to be important to keep that frequency high for this population. Following exercise training, chronic decreases in blood pressure are observed. So we saw that 16 to 32 week study having a better effect than most hypertensive medications. A combination of aerobic and weight training should be performed. Again, if it's going to be that weight training, low repetitions, and progressing to making more sets. Exercise can stabilize or regress atherosclerosis. So all those physiological adaptations improve the compliance of the cardiovascular system, lowering your risk of a blockage or restriction in blood flow. Patients with peripheral vascular disease respond well to exercise rest interval training, and significant improvements in walk time and quality of life are observed after 12 weeks of training. Thank you, guys. Any questions, please don't hesitate to email, and enjoy your public holiday.